section, we'll be discussing cardiac diseases in pregnancy. I am Dr. Akitunde Olusegun Feyintola, a senior lecturer from the Department of Obstetric Gynecology and Perinatology, Obafemi University, Ile-Ife, Osun State, Nigeria. At the end of this section, you should be able to describe the changes that occurs in the cardiovascular system of a pregnant woman, as well as the salient indicators of cardiac disease in pregnancy. You should be able to investigate thoroughly a woman with cardiac disease in pregnancy and be able to carry out preconceptional care for such a woman before next pregnancy, or in a woman who has not been pregnant before, who has a cardiac disease before embarking on pregnancy, and also be able to discuss various complications of cardiac disease in pregnancy. At the end of this section, this should improve your knowledge about carrying out proper preconceptional care for a woman with cardiac disease who want to embark on pregnancy, and apply what you have learned in subsequent management of patients with cardiac disease in pregnancy. Heart disease is quickly becoming a leading cause of mortality, maternal mortality globally. It constitutes about 1% of all pregnancy. Why is this topic is important? Because most of the patients with significant symptoms will have higher rate of complication during pregnancy, and they can succumb to this complication during pregnancy, while those who have mild symptoms with stenotic lesion can rapidly deteriorate during pregnancy, while some conditions are associated with very high risk of maternal death, and patients will need to be counseled appropriately about this. About the cardiovascular changes in pregnancy, from the table above, you will see that as early as 12 weeks of pregnancy, the heart rate increased about 40%, while the stroke volume increased about 50%. This puts a lot of pressure on the heart, as will be discussed later, and cardiac output increased about 50% as early as 12 weeks of pregnancy, as well as the left ventricular ejection fraction. All the cardiovascular changes in pregnancy are geared towards improving blood flow to the fetal placenta unit, and these significant hemodynamic changes are apparent as early as pregnancy, as early as possible in pregnancy. These changes put a lot of burden on maternal heart and may cause symptoms for those who have cardiac disease, while women with major cardiac dysfunction may experience worsening of their condition during pregnancy. Some of them with no previous symptom can develop heart failure in the interpartum period and in the immediate puerperium, and this should be borne in mind while managing them. Most of the effect of this condition on the heart is due to the cardiac output. Now, around the period of delivery and the immediate peripartum, there is a further increase in cardiac output because of the fear, pain, and anxiety of labor. Evidently, each contraction pushes about 300 to 500 ml of blood into the systemic circulation, and this further increases the cardiac output during labor and puerperium to about 20% from what it was during pregnancy. In the immediate postpartum, the relief of the aortocaval compression also further increase autotransfusion and increase systemic circulation. This will further increase the cardiac output in this woman, thereby predisposing them to cardiac disease and its complication during the immediate puerperium. Considering the fact that cardiac disease carries major morbidity and mortality during pregnancy, it is very important that patients they are seen before pregnancy. Ideally, these patients should consult their physician before they go into pregnancy. That makes preconceptional care an important element in the care of patients with cardiac disease in pregnancy. This will allow them to know when it's optimal for them to get pregnant, and their risk will be assessed during this period to know whether they can actually embark on pregnancy, whether they will need to wait a little while, or they will need to have some investigation and surgery done before they embark on pregnancy. And this is very important. Around this period too, when we want to review their drug For those who are on drugs that are transgenic, they may need to change their drug to drugs that are safe in pregnancy. And also, when they need corrective surgery, this can be done before they embark on pregnancy. Evidently, evidence has shown that risk increase in pregnancy, and these have been grouped by different classifications. The classification on the board today stratify patients' risk of mortality to 3. The first group, they have minimal risk. These are the people that have New York Heart Classification 1 and 2 with some mitral stenosis or ventricular septal defect, or they have a corrected bioprosthetic valve. They have a valve placed which are bioprosthetics. These have fewer or minimal maternal mortality rate during pregnancy. While group 2 and group 3, they have moderately increased and high risk of dying during pregnancy. This includes patients who have mitral stenosis, patients with class 4 or class 3 New York Heart Classification, those who have aortic stenosis or Marfan syndrome with the effect on the aortic root. All these patients will have significant mortality. And those who have high risk of mortality, they need to be counseled appropriately before pregnancy. In fact, pregnancy is contraindicated in people with Marfan syndrome that has aortic root dilatation more than 4 centimeters. Those who have pulmonary hypertension with pulmonary vascular resistance above 6 Wood unit, and those with moderate to severe left ventricular tract obstruction, and those who have ejection fraction less than 0.3 should be counseled against pregnancy. And if they are seen in pregnancy early enough, they can be counseled for termination of pregnancy because the risk of mortality in them is as high as 50%. A patient seen for the first time in pregnancy with cardiac disease needs a multidisciplinary approach in their management. They should be seen by the cardiologist, obstetrician should see them. They need to see clinical geneticists because of some of the conditions that cause cardiac disease are congenital in nature. The anesthesiologist need to see them, and the neonatologist need to be involved early in their management. And what we do for them include careful medical history for such patients with comprehensive examination and some investigations carried out for them. While investigating a patient with cardiac disease, challenges are available. There are many challenges that can occur in them because most of the symptoms of cardiac disease actually mimic symptoms of normal pregnancy. Just as I explained the other time, some of these cardiovascular changes are actually produce symptoms that can mimic that of cardiac disease. The underlying issue here is that it is dangerous to miss a patient who has cardiac disease because mortality is higher in them if you miss them. But also, it is also not very good to name a woman as having cardiac disease when there is no cardiac lesion available in such a patient. So there should be a balance when you are examining this patient, having all this important information in mind. Most of the symptoms in pregnancy that mimic cardiac disease, some of cardiac disease in pregnancy, are due to weight gain, the pressure effect of the enlarging uterus on either the blood vessels or the diaphragm, and also physiological anemia that are seen in them. Most of these patients in normal pregnancy complain of reduced exercise intolerance and easy fatigability because of the weight gain and the pressure effect of the enlarging uterus. And once in a while, normal pregnant women can present with syncopal attack. This must not be misinterpreted as cardiac disease in pregnancy. They need to be, all these symptoms need to be borne in mind when we are seeing a patient in pregnancy. I'm not going to misinterpret them as if they have cardiac disease in pregnancy. Sometimes the hyperventilation as a result of the effect of progesterone on the respiratory center in the brain or the pressure effect of the gravid uterus on the diaphragm can be misinterpreted as dyspnea in this patient. However, there are specific symptoms that once we see them, they increase the suspicion of cardiac disease in pregnancy. This includes the presence of paroxysmal nocturnal dyspnea. Nocturnal cough is one of the leading early signs of cardiac disease in pregnancy. If people present with this symptom should not be overlooked. They should be evaluated further. While examining this patient, also, one should bear in mind some salient features of congenital cardiac disease that may be seen in them. There are skeletal features, finger clubbing, and other facial features can be seen in them. Evidence of central cyanosis while examining this patient may be a pointer to a congenital cyanotic heart disease, and such a patient will need to be probed further about the family history of cardiac disease or sudden death in them. Patients who have had episode of cyanotic heart disease, cyanosis during birth or early childhood also will come under this condition. Now, patients with autopnea, paroxysmal data, hemoptysis, chest pain, persistent palpitation, we should look at them critically. These are features that are highly suggestive of cardiac disease in pregnancy, and not just the effect of pregnancy on cardiovascular system. While examining the chest of this patient, the heart sound, usually in pregnancy, the first heart sound are widely split, and this can be misinterpreted as fourth heart sound. This should be borne in mind. A loud first heart sound may be a pointer to mitral stenosis, while a low pitch first heart sound may be a pointer to a case of first degree heart block. All this need to be put in mind while we are examining any patient in pregnancy. However, diastolic murmur is highly significant while evaluating a woman for cardiac disease. For such a patient with diastolic murmur, they need to be evaluated properly to rule out cardiac disease in them. So the common investigations that are done in a patient with cardiac disease in pregnancy who have a suspicion of cardiac disease in pregnancy include Doppler echocardiography, Doppler ultrasonography, electrocardiography, chest radiography, right heart catheterization can be done for them, and some other investigation. But these are the common ones that are done in this patient. Ideally, because of the effect of radiation, chest X-ray should not be done too casually during pregnancy. They should be done when it is absolutely indicated. Transthoracic echocardiography is an important test. Investigation should be carried out in women with cardiac disease in pregnancy. This in conjunction with Doppler ultrasonography will help to examine the anterior chamber of the heart to look at evidence of septal defect, look at the injection fraction. Also, with this, one can also measure the pulmonary vascular pressure in such patient. This can be measured with the use of transthoracic echocardiography. But the posterior compartment of the heart may be difficult to examine with transthoracic. In this case, the transesophageal echocardiography is indicated. This will help us to examine the left ventricle and left atrium, vis and vis the mitral valve and aortic valve can be examined properly with the use of transthoracic echocardiography. Interpreting electrocardiography in pregnancy in a woman with cardiac disease, one should have it in mind that there are some cardiovascular changes that can influence the electrocardiography in a woman with cardiac disease. So one should also look at that appropriately and not misinterpret normal changes. Some normal changes that occur in electrocardiography as if the patient has cardiac disease. Right-sided catheterization becomes very important in a patient who has pulmonary hypertension or condition that can predispose to pulmonary hypertension. Also, it can also be used in monitoring the patient during labor. These are some of the investigations that are common that are done during pregnancy. Genetic testing comes in and counseling, especially because most of the patients with cardiac disease, most of the people with congenital heart disease now survive till adulthood and they embark on pregnancy. Genetic counseling will help to look at patients who has evidence or issue suggestive of congenital heart disease, to look at the risk of the baby developing the same cardiac disease or other cardiac abnormality during pregnancy. And if there's evidence of that, patient can be investigated along the mother. The fetus can be investigated along the mother during pregnancy. The New York classification has been able to classify the functional activity of a woman during pregnancy and generally, and they are classified from class 1 to class 4. This classification has been modified to improve the risk categorization of a woman in vis-a-vis the development of cardiac complication during pregnancy. So a lot of things have been done to modify this classification to improve the risk stratification of development of cardiac complication during pregnancy. One of these is the Shaw stratification of cardiac disease in pregnancy that was brought out in year 2001. It's categorized and point by point risk classification have been done with this classification. Now, in general, for a woman with cardiac disease in pregnancy, team approaches the thing. While managing these patients in pregnancy, these four changes must be borne in mind. The fact that cardiac output increased by 50% in pregnancy will worsen their symptoms and warning to monitor them closely. The fact that in labor and puerperium there is further worsening of the cardiac output, increase in cardiac output and blood volume, which can also tilt them into heart failure for the first time in their life during delivery and puerperium. One should have it at the back of our mind too. And the fact that there is a decline in systemic vascular resistance will put a lot of pressure on some cardiac lesion. This also needs to be borne in mind. And finally, the pregnancy-induced hypercoagulability can also worsen the condition of some cardiac condition. For example, a patient who has valvular disease or mechanical valve replacement, they may have problem with hypercoagulability that can be worsened with the pregnancy-induced hypercoagulability. Most of the patients with cardiac disease may scale through pregnancy without difficulty, and some of them develop their symptoms for the first time during labor, which have been said before. Congenital cardiac failure in them is of a gradual onset, and that will help us as physicians to be a step ahead of the development of this condition, and we can also prevent it from happening. Attention should be directed towards prevention and early detection of heart failure in them. Because of the risk of endocarditis in this set of people, infection prevention is very important. Some of these men may need to be placed on prophylaxis antibiotics throughout pregnancy or around the period when they want to have any form of procedure that can increase the risk of infection in them. Where this is available, pneumococcal and influenza vaccines are recommended in some of these patients. Then lifestyle modification is important. For those who are smoking, they should stop smoking. While managing them in labor, the vaginal delivery is the safer route of delivery in them because of the risk of excessive blood during cesarean section that can tilt this patient into complication. However, there are some indications for cesarean section in these patients. Patients who present with labor on oral anticoagulant, ideally a patient with oral anticoagulant should have stopped oral anticoagulant from 36 weeks of pregnancy. But some people can fall into labor while on oral anticoagulant. Allowing vaginal delivery in such a patient will lead to severe hemorrhage. So this way is better managed using delivered by cesarean section. Patients with a severe aortic pathology should be delivered by cesarean section. While those who have severe pulmonary hypertension and intractable heart failure should also be delivered by cesarean section. In those who have been shown to be generally safe in them, pain relief in pregnancy, pain relief during labor is very important because of the effect of pain on cardiac output that can worsen their cardiac function in this patient. They tolerate epidural anesthesia best, and other opioid analgesics can also be added to their drug in labor. Second stage of labor in them should be shortened because we don't want to with the use of forceps and vacuum extraction. During labor, pulmonary artery catheterization is very important for continuous hemodynamic monitoring in them, and labor should be monitored in recumbent position with lateral tilt. The vital signs of the patient should be checked regularly because tachycardia and tachypnea are signs of impending left ventricular failure. This must not be missed. They must be picked on time. In the puerperium, that has been said, because of the effect of the contracting uterus and the relief of the pressure on the aortocaval compartment after delivery, a lot of blood is shot to the systemic circulation and cardiac output can increase suddenly. If this happens in them, this can tilt this patient into failure. So they need to be monitored closely in the immediate puerperium for the complication of cardiac disease in them. Active management of status of labor to prevent primary is very important. Anemia is corrected accordingly, and they should be placed on prophylactic antibiotics and thromboprophylactics after the delivery. Patients with cardiac disease should be counseled to limit their family size, and this can only be done with the help of contraception. Sterilization is the best option for them. But that method is not reliable because of the risk of failure of this method. Combined contraception, because of the risk of coagulopathy in combined contraception, these have been discouraged in patients with cardiac disease. But progesterone only contraception can actually be used in them. Both the injectable and the implant are safe in this set of patients. Patients who have had previous successful repair of their cardiac disease can actually go to pregnancy without so much complications. And with this, it's very important we can counsel them to attend pregnancy when they have had a successful repair. However, some cardiac disease will not manifest until during pregnancy, and physician must be ready to pick those conditions when they manifest during pregnancy. Patients who have had a valvular replacement during pregnancy, they carry significant morbidity and mortality before pregnancy. They carry significant morbidity and mortality during pregnancy, and this patient should be specially monitored during pregnancy. In fact, for some of them, we need to carefully consider whether they should be allowed to go to pregnancy or not. And for those who have embarked on pregnancy, they should be anticoagulated throughout pregnancy. Some of the complications that I have seen in those patients who have had a valvular replacement include thromboembolism, maternal death can occur in them. They can have congenital cardiac failure and primary some hemorrhage because of the thromboprophylaxis they are on. For those patients who has valvular replacement, their fetal outcome also is generally poor. So this should be discussed with the patient before they embark on pregnancy. Now, a topical issue here for those who are on mechanical valve replacement is the use of anticoagulation throughout pregnancy. Evidence has shown that oral anticoagulants, warfarin or coumarin, they have better thrombolytic effect than heparin, whether unfractionated or low molecular with heparin. However, this group of drugs have embryotoxic effect, and they have embryopathic effect. And also, when they are used towards labor, they can lead to severe primary postpartum hemorrhage. Because of this, for a patient who is embarking on pregnancy, their warfarin should be changed to heparin. And when they get pregnant, they should use this heparin for the first 12 weeks of pregnancy. This can be changed to warfarin in second trimester, and by 36 weeks of pregnancy, warfarin should be stopped and the patient should be started on heparin to balance the risk of warfarin, embryopathy, and primary hemorrhage with that of the thrombolytic effect that they have, which I've explained in this place. For patients who have bowel prosthetics, their own valves are less thrombogenic. They will not require prolonged use of anticoagulants throughout pregnancy. In fact, some of them will not even need anticoagulants at all. So usually patients with bowel prosthetics do not need anticoagulants. And the slide above shows the recommended dose of unfractionated heparin that patients should use. At least you should use between 30 to 35,000 internal units twice daily, and they should be monitored. The choline profile should be monitored twice every week. For those who are on warfarin, they can take between 2.5 and 3 and 5 milligram daily, and they should target an internal nominal ratio between 2 and 3 in them. The substitution should be done just as have been discussed earlier. Heparin should be stopped just before delivery. If delivery occurs while a woman is still on anticoagulant, especially heparin, the effect of it can be blocked by the use of intravenous protamine, especially for those who encounter heavy bleeding while they are using the anticoagulant. Now, for those on mechanical valve, that has been explained, they need to stop the anticoagulant before delivery, but they can start it 6 hours after vaginal delivery, while they start it 24 hours after cesarean section. Warfarin can be safely given a woman who is breastfeeding because excretion in breast milk is negligible. Of course, there are some cardiac surgery can be done in pregnancy, but they are uncommon. But sometimes patients may need cardiac surgery during pregnancy, as this can be a life-saving in them. For a parent who have cardiac surgery in pregnancy, the outcome of the fetus, they are largely poor, but that will be life-saving for the mother. There are different tests that can be done, and some of them have been mentioned in the slide above. You can do valvular, percutaneous, percutaneous, catheterized valvular valvotomy can be done in some of these patients, and this has largely replaced the former valvotomy that is being done. Cardiac transplant can take place in some patients as a last resort who have cardiac disease before pregnancy. Before now, the problem with vasculopathy and rejection of allograft is the major problem with cardiac transplantation. But the first successful pregnancy was reported in 1988 in a woman who has a cardiac transplant. And since then, available data have shown that cardiac transplanted heart respond normally to pregnancy-induced changes. That has been the general management of patients with cardiac disease. Just beyond one or two specific cardiac disease and what you do differently when you are managing these patients. In valvular heart disease, mitral stenosis is the most common stenotic valve disease that is seen, and usually they are caused by rheumatic fever or endocarditis that lead to this. Usually with mitral stenosis, there is dilated left atrium. This can increase left atrial pressure and can lead to pulmonary hypertension later. Managing this patient, we need to reduce physical activity during pregnancy. We need to reduce dietary sodium intake, and we should place them on diuretic therapy. This will help them to tolerate pregnancy better. Sometimes they can develop acute atrial fibrillation. For such, verapamil should be handy in their management, and sometimes they may need electrocardioversion. For those who are on chronic fibrillation, they will need to be on beta blockers or digoxin or calcium channel blocker as their condition may demand. Patients with mitral stenosis should be on anticoagulation throughout pregnancy because of the risk of thromboembolism that can occur in them. While managing them in labor, pulmonary artery catheterization is of utmost importance in this patient because of the risk of pulmonary hypertension, as has been earlier discussed. Vaginal delivery is better in them, they tolerate epidural better, and they should be on antibiotic prophylaxis because of the risk of intrapartum endocarditis. Mitral insufficiency is another problem, another valvular heart disease problem. The commonest cause of the chronic regurgitation is rheumatic heart disease. Once in a while, we can see mitral valvular prolapse can also occur from dilated myopathy. Or sometimes antiphospholipid syndrome can also cause this condition. And acutely, mitral insufficiency can occur from ruptured chordae tendineae or infarction of the papillary muscle of the mitral leaflet. Mitral regurgitation leads to left ventricular dilatation, and once in a while, one can see evidence of left ventricular eccentric hypertrophy in them. This mitral regurgitation is a condition that is well tolerated in pregnancy because of the reduction in the systemic vascular resistance in these patients. So they tend to tolerate pregnancy better than those who have mitral stenosis. While congestive cardiac failure also is really developed in them because they tolerate pregnancy better. But they need to be on intrapartum prophylaxis against endocarditis. The last valvular disease I will talk about here is the aortic stenosis, which is a disease of aging. But it has been seen in women less than 30 years for those who have congenital heart lesion, and these are reducing gradually in the developing world, in developed world, because of the reducing incidence of rheumatic heart disease. So just to mention some of the things that can happen. Aortic stenosis is very dangerous, and this way must be thoroughly investigated before they go into pregnancy, because the severe form of it carries maternal mortality rate of as high as 8%. Patients with valvular pressure gradients more than 100 millimeter of mercury is at the greatest risk of maternal mortality. They should be discouraged from getting pregnant. While they are pregnant, those who are asymptomatic will need to be monitored closely, while the symptomatic patients should limit activity and they should be placed on treatment for prevention of infection. They should be placed on antibiotic prophylaxis. For those who have persistent symptoms despite bed rest and antibiotics, they may need to have valvular replacement during pregnancy, and this carries a major risk of mortality in them. For those who survive it, it improves their outcome. In this patient with aortic stenosis must not be placed on diuretics. For this, we put the heart on under a lot of pressure because of the reduction that can happen this can lead to hypovolemia in them, and this can worsen their condition. So that's as we have discussed. Now, for patients with congenital cardiac disease, majority of them survive until adulthood. So we are beginning to see some of them now embarking on pregnancy. So we must have it in mind that some of our patients who have cardiac disease may have congenital heart disease, and that should influence the way we manage such patients. The second most common type of congenital heart disease is the atrial septal defect, and these have been shown to manifest around the third or fourth decade of life. And because most of our women now delay pregnancy, some of them may get pregnant and become symptomatic with this condition when they have it. It is not discovered early, but when they are discovered, the risk of pulmonary hypertension is very high in them, and this must be properly managed when they are seen. Ventricular septal defect is another very important congenital heart disease that we need to look out for when we see patients, especially because of the risk of Eisenmenger syndrome that can develop in them. It's very important that we monitor them closely when they are seen in pregnancy, and they are monitored appropriately with pulmonary artery catheterization when they are in pregnancy. In them, very importantly, vaginal delivery is better than cesarean section in them. Evidence of genetic predisposition must be looked out for while we are managing them. We should investigate properly. Them and their fetus should be investigated for concurrent cardiac lesion in them. Thyroid heart disease is also a common congenital heart disease in pregnancy, which we are now beginning to see. And very importantly, it becomes important because of the effect of this condition on the outcome of pregnancy. One may need to counsel the woman appropriately before pregnancy, but when they come in pregnancy, one may need to counsel them further, especially for those who have tetralogy of Fallot. They will need to be properly monitored during pregnancy, because if they have not been repaired before pregnancy and their symptoms worsen, they may need to have repair during pregnancy, and that is the only thing that can improve prognosis in them during pregnancy. Another form of cyanotic heart disease is the Epstein-Barr anomaly that occur with Epstein-Barr anomaly of transcubic valve or transfusion of great artery. Cyanotic heart disease generally have poor outcome in pregnancy. When they are unrepaired, the mortality is about 10%. Their complications include chronic hypoxia that can lead to fetal loss, preterm delivery, preterm labor can lead to low birth weight and can have intrauterine fetal death. Patients should be counseled to have repair to improve success in subsequent pregnancy. Labor should be managed appropriately. We should look out for Eisenmenger syndrome in patients who has evidence of pulmonary hypertension, or those who have problem with left ventricular septal defect because of the risk of Eisenmenger syndrome in them. Patients with Eisenmenger syndrome should be counseled against pregnancy, but if they develop in pregnancy, they will need to be monitored closely for the complications that can occur with them. Pulmonary hypertension can either be primary or secondary, depending on whether there is cardiac disease or not. The primary pulmonary hypertension is very rare. There are no background cardiac lesions, and this carries a very high mortality rate. If this is peaked before pregnancy, patients should be counseled against pregnancy. If they have peaked early enough in pregnancy, patients should be counseled against continuation of pregnancy, will be counseled for termination of pregnancy. Pulmonary hypertension could either be primary or secondary, and when it is primary, it carries a very high prognosis for mortality in this patient. If this is discovered before pregnancy, patients should be counseled against pregnancy, and when they are seen in pregnancy early enough, they can be counseled against continuation of pregnancy. Should counsel them for therapeutic termination of pregnancy because of the risk of mortality in these patients. Usually, patients with primary pulmonary hypertension, there is no cardiac disease, but it has been implicated in patients with sickle cell disease, patients who are HIV positive, those who have pulmonary embolism, thyrotoxicosis, or patients with antiphospholipid syndrome. There are those who have been seen with primary pulmonary hypertension. So, when you have patients like this, we need to monitor them properly for conditions like this. When the mean pulmonary arterial pressure is above 25 mm of mercury at rest or 30 mm of mercury with exertion, is a salient pointer to the patient is about developing pulmonary hypertension. They need to be monitored closely with cardiac catheterization. If they are peaked in pregnancy, they may need to be managed throughout pregnancy with nifedipine and prostacyclin. But if they are peaked before pregnancy, it is better to have treated them for at least 1 year on nifedipine and prostacyclin before they embark on pregnancy, because mortality rate without treatment is very high in them. For those who are symptomatic during pregnancy, we need to limit activity, monitor them on admission once in a while in cardiac position, then they need to put them diuretics and supplemental oxygen, and they need to be managed appropriately. It's very important that we allow vaginal delivery in them. If this is done, second stage of labor should be monitored, should be shortened with the use of forceps or vacuum. It is very important to put in place pulmonary artery catheterization to avert sudden hypotension that is not picked on time. This should be picked on time and managed appropriately. The last component here is the peripetal cardiomyopathy, which was the diagnosis criteria was put in place in the year 2000, and this is defined as the presence of heart failure within the last month of pregnancy, from 36 weeks up to the first 5 months post delivery. In this condition, there is absence of any form of identifiable cause of heart failure, and also there is no recognizable heart disease prior to the last month of pregnancy. Endocarditis in pregnancies is a potentially life-threatening cardiac complications in pregnancy. For those who have background cardiac disease, the risk is higher than the general population, and when this occurs, it increases the risk of mortality in patients. That's why it is important that every patient with cardiac disease should be on antibacterial prophylaxis to prevent the development of this condition. It is uncommon in pregnancy in a woman who has no background cardiac disease. According to the American College of Cardiology and American Heart Association, they endorse the use of antimicrobial prophylaxis to prevent this in all patients who have cardiac disease. And although some of these patients have been reclassified, based on the risk classification, one can determine whether they will need antibiotic prophylaxis throughout pregnancy. But what's important is that patients with cardiac disease must have antibiotic prophylaxis. Almost all of them will have antibiotic prophylaxis, especially during labor and in the puerperium. But for those to classify their risk as whether they will need or not, this risk has been classified as high moderate risk of developing endocarditis. For those who have prosthetic valve, almost always patients should be placed on antibiotic prophylaxis throughout pregnancy. And those who have prior bacterial endocarditis or complex heart disease, or those who have had surgical correction, should be on antibiotic prophylaxis because of the risk of endocarditis in them. While those who have moderate risk, those who have had previous history of rheumatic heart disease or who have mitral valve prolapse or regurgitation, they also need to have these antibiotics. While those who are low risk, maybe those who have prostatic atrial septal defect, this type of patient may not need antibiotic prophylaxis, but they should have it during labor. Marfan syndrome is a condition that is worth noting because it's an important connective tissue disorder that are becoming prevalent during pregnancy in the developed world, and this need to be mentioned for the sake of emphasis. Patients with Marfan syndrome who has no aortic root involvement should be allowed to go through pregnancy, but they need to be monitored for the risk of acute aortic dissection during pregnancy. They need to be monitored closely. Patients with Marfan syndrome who has aortic root dilatation more than 4 centimeters should not be allowed to go through pregnancy because of the risk of sudden aortic root dissection that can occur in them, that can lead to a mortality of aortic root dissection in this patient is close to 50% when this happens during pregnancy without prompt intervention in them. Also, one need to look at other conditions that Marfan syndrome can present with that can also complicate pregnancy in such a patient. In summary, we have been able to discuss the different cardiovascular changes that occur in pregnancy and how this influence the symptomatology of patients in cardiac disease who are pregnant. Also, we have discussed the symptoms that are pointers to cardiac disease in pregnancy. We have also discussed this. Then we've discussed how to investigate a patient with cardiac disease during pregnancy. We also discussed at length the preconceptional care that should be given to this set of patients, and also we described the general and specific management of various cardiac disease during pregnancy. Successful pregnancy can only be achieved when cardiac complications are managed appropriately during pregnancy. In order to optimize maternal and neonatal outcomes, close collaboration between the maternal fetal unit and other specialists like cardiologists are very important in this set of patients. These are the references. At the end of the research, I was able to put out some questions here for you to answer, to see how much of this you have been able to gain from the discussion of this section. There's a clinical scenario, then we have one long essay. That's a clinical scenario that you can answer, just to see how much of what you have learned from this section. Also, we have 2 short essays there that will also test your memory. Then 5 single best option and 5 multiple choice questions that you can try your hand on at your leisure. Thank you very much.